to move my own slides if it's possible. So the topic is about dissection. Is always a big challenge and a big concern when you face this kind of sometimes dramatic situation. So we focus our attention about, not my disclosure for sure, but you need to focus our attention in this particular agenda, because we are starting in 2017 the European Society of Vascular Surgery guidelines about the semi-thoracic aorta management. 3 years later, by fortune, we collect the reporting standards from the SBS, STS, and 2 years later, 2 international guidelines almost simultaneously reach the publications from STS and from the AHA, from the American Heart Association, concerning the same kind of topics about the aorta. And 2 years later, by coincidence, another societies, the European Association of Cardiothoracic Surgeons, and again STS, guidelines, and just last month, the European Society of Cardiology published their own aortic, peripheral, all the vascular guidelines together in European Heart Journal. So too many guidelines for probably see and told about nothing new. That is our starting point. The starting point is the European Society of Vascular Surgery guidelines. As you can see here, for complicated cases, type B aortic dissection, complicated cases, there are no any doubt. You need to intervene, and the level of evidence is C, is very low for sure. And also we start with introducing a new concept that is the selective consideration about some kind of uncomplicated type B aortic dissections, because not all the uncomplicated are equal. So we introduce here the aorta at risk, or dissection at risk. So in terms of chronic dissections, the diameter is quite arbitrary, between 55 and 60 sometimes, but again, the evidence is very poor. What about the repair of these chronic type B dissections? Open repair seems to be the gold standard, and for patients with a moderate to high risk, surgical risk, the endovascular repair should be considered in some cases in dedicated centers. So we discovered and we published this kind of gaps in evidence when you talk about the dissections. Need for more morphological and dynamic features to identify the predictor factors that identify some kind of aorta at risk. Need for a consensus definition of subacute phases, and also need for data in order to know the natural history of the chronic type B aortic dissection, and also to probably to define a correct threshold. We know the threshold for the aortic repair, for abdominal aortic repair, but we don't know about the thoracic aorta, and also for a type B aortic dissection in the chronic phases. For sure, we need larger series of long-term outcomes to convince people about the open or endovascular repair preference. But the reporting standards coming from the STS, SVS add 3 important points in my view. The first one is to define the type B aortic dissection when the main tear is just behind the brachiocephalic trunk, not behind the left subclavian artery. The second one is to introduce those kind of features that can define your aorta at risk, those kind. This high risk, again, aorta at risk, refractory pain, hypertension, body pleural effusion, more than 40 millimeters in diameter in the early phases, malperfusion, radiographic malperfusion, readmission, whatever. And again, we have another point. The subacute concept appears clearly written down black over white in the guidelines on this particular report. What about the guidelines coming from the STS? So in terms of acute type B aortic dissection and complicated, the prophylactic TIVR just again in aortic, there are some complications related to the aorta that can lead to the death. So again, that concept of aorta at risk. About the chronic ones, 55 up to 60, or 1 centimeter per year of growing. But let me to emphasize, let me to just pay attention about the last point in the right side of the slide. TIVR alone as a therapy is not recommended for chronic type B aortic dissection, especially when the dissection crosses the diaphragm up to the abdominal aorta in these phases. So about the American Heart Association in the same year, very few words about that. It was when you have in acute phases, again, the term of high risk appears here more clearly and also can be considered TIVR for these particular patients. And also for the chronic one, and again, the 55 millimeter diameter is a threshold for those guidelines. What about the European Association of Cardiothoracic Surgery? And again, we have the high-risk features, and again, aorta at risk is another important point, and is recommended to be considered to take TIVR early phases for those particular patients. What about in the chronic phase? 55 seems to be the threshold, and probably less when you have historical or some kind of orthopathy, historical orthopathy. And recently, the last one guidelines use clear recommendation for complicated one, and for a non-complicated, TIVR could be considered in a subacute phase, should be considered in order to prevent those particular high-risk features to lead to aortic complications. And that is an interesting algorithm, and you can also review in the paper alone. That is clear for complicated. You can see here, and for uncomplicated is another kind of risk factors in this list, and also you can choose for surveillance or just TIVR. Not all type B aortic dissection deserve an endograph inside. And again, those are particularly some features in order to classify your aorta at risk. In terms of chronic, the European Society of Cardiology also emphasized the threshold is a 60 millimeter diameter. No clear consensus about that, but 55 could be relatively in chronic, in familiar and familiar orthopathies. So in summary, recently many guidelines documents have been published about type B aortic dissection with poor level of evidence, mostly level C, no evidence, mostly are consensus. For complicated aortic acute type B aortic dissection, intervention is recommended. It is clear recommendation. For acute type B aortic dissection at risk should be considered for TIVR in a subacute phase. That means between 15 and 90 days. For chronic type B aortic dissection with diameters 55 to 60 millimeter over that diameter seems to be threshold for the intervention. 55 or less in some kind of orthopathies, genetic orthopathies. TIVR alone is not recommended in a chronic type B aortic dissection if there is formation across the diaphragm down. And perhaps the most important recommendation, which does not appear in any guideline at the moment, is to focus the efforts on preventing aortic complications by effectively treating early stage dissections, because the chronic dissections are much more complex and dangerous than probably the acute phases. So thank you very much for your attention. I invite you to Barcelona next year.